Good afternoon, everybody. It is Dr. Kachikian here from the Black Hills Regional Eye Institute, and we're just going to do another routine case side port here. Diamond 1mm side port. Put a little Lido with mixed with BSS, and then Visco. Get a nice wave of viscoelastic across the cornea. Mark with a 5mm corneal marker, and then we'll take our time making our main incision. It's a 2.4 single bevel keratome. And really just want to make it as square as possible. That's real nice. Now we use our Utrata and 0.12 forceps. I like to use the 0.12 to just stabilize the eye. It gives me control. And we will create our capsulorhexis. Just gently going around, trying to stay equidistant from the iris as we come around. Make sure that you put the leaflet of the anterior capsule back where you want it. Put it back where you want to grab it when you let it go. Okay, that's very important that you relocate that leaflet in a place where you can re-grasp it. Now we use some BSS, do some hydrodelineation. There's a good fluid wave. Look at the other side, make sure the lens spins. There you go, and hydrodissection now. See if we get a little golden ring there. There we go. Perfect. Then we'll reinflate with visco just to protect that cornea as much as possible. Check the flow. See, there we go, just a little bit of flow, and that's it. An average sized tip length. And we'll clear out the anterior epinucleus and visco and then sculpt. And we'll take our second instrument and then crack. I could sculpt it more deeply, more proximally, but I tend not to. Just extra phaco energy that I don't think I need. Sometimes I will if the lens is real soft and doesn't want to crack, or it's got that gummy consistency and doesn't want to crack. But we sculpt, we rotate, we chop, and we take out the first quadrant. Here's that second quadrant. And as you rotate, after you rotate, you can propagate that initial crack that you had. Get our pieces out just right in the center there. We're still kind of in the bag. There we go. We're kind of in the bag there. Real nice. Staying away from the endothelium and also pretty far away from that posterior capsule. Notice the phaco tip stays central until we go out for this kind of epinuclear shell. And that flips in pretty nicely. And if it doesn't flip in, you just keep rotating. Rotate till you get a purchase on a piece of epinucleus that's going to work for you. So we're going to have to rotate this around. And then this will probably all kind of flip out of the bag. There we go. This part, a lot of people don't like removing epinucleus like this. They just want to get it out with the nuclear portion of the cataract, which is fine too. But I usually will separate them. Now we'll go back in with our IA. And just peel those pieces of cortex off there. You can tell on half the side there's exclusively cortex, and the other half has a little bit of maybe epinuclear material associated with it. That's totally fine. Perfect. Just kind of gently peeling. I like to get all the strands off, and if the strands don't come, if there's a few there still, that's when I will usually use the BSS to power wash. I may always use the stream of BSS to check the capsule fornix and make sure there's nothing hiding. You'd be surprised at how oftentimes there is just a piece of cortex that's adherent to the capsule that's stuck in the fornix. It just didn't come out. Now we'll inflate with Provisc and use a sweeper to remove those anterior lens cells. Just makes for a cleaner case and less inflammation. The jury's kind of still out on PCO, how much this helps PCO. I always find it interesting. There'll be some cases you see these patients years later and they have no PCO, even in just one eye, and then the other eye you did, a few years later has denser PCO, and you wonder why. one eye versus the other was so different with the same lens material. We'll get our lens in here. This is a Clarion. Just kind of wiggle it in, inject it. See how it unfolds. I usually use a second instrument to unfold the lens, but noticing recently it's been really warm in the OR. And because it's been so warm in the operating room, the lens unfolds. You don't even need that second instrument. So I do think in cases where docs tell you don't need a second instrument to unfold the lens, I think a lot of it has to depend on the temperature. If the temperature is warm enough, that lens will pop right open. But typically in our ORs, it's kind of cold, and so the lens doesn't open all that well, and so that's when you'll use a second instrument, Sinskey hook or something, to coax the lens to open a little bit better. Now you can see our Provis coming out. Get it right up against the cornea there. Obviously don't hit the endothelium, but you want to get all of your viscoelastic out. I'll usually go around the fornix to make sure we've got all of it. Here we're taking off maybe some anterior cortical material there that got left behind. Good. And now we will seal up our incisions. I do hydrate the walls as well as the roof. We've talked about this. I think it makes for a better seal, and that edema will be gone the next day. You don't want to hydrate into the center, obviously, of the visual axis. A little bit of irrigation in the angle to make sure there's no retained pieces of nucleus and no retained viscoelastic. We have good coverage of our capsule there. We'll hydrate the side port. We'll get a little bit of moxie in the anterior chamber to make sure, or to reduce the likelihood of any endophthalmitis. As you can see, the cornea is coated with viscoelastic. We do that. We'll check our incisions, and we'll be done. All right, you folks, have a great day.